Welcome to the first episode in our special crosscast series on IMID and obesity, shared across RhAPPcast, GHAPPcast, and Dermcast, which are the official podcasts of RhAPP, GHAPP, and SDPA. I'm your host for today's episode, Amanda Mixon. I am a PA in Rheumatology and the current president of RhAPP. And I'm thrilled to kick off things with a powerful conversation called Obesity and IMIDs, Unpacking the Epidemic and its Far-Reaching Impacts. The series follows a unique boot camp series presented live at the national meetings of RhAPP, GHAPP, and SDPA, as well as MAP, bringing together advanced practice providers from rheumatology, GI, metabolic health, and dermatology to explore one of the most under-recognized but clinically significant intersections in medicine, the link between obesity and immune-mediated inflammatory diseases. In today's episode, we will dive into the evidence supporting the connection between obesity and IMIDs and unpack physical, emotional, social, and economic toll that these comorbidities impose on patients and our healthcare system. Joining me are three phenomenal experts, each representing one of the specialties involved in this initiative. If you three would please give an introduction, given our cross-posting this series to ensure all organizations can learn, I'm sure we're fresh faces to a lot of listeners.
Hi, I'm Laura Bush. I'm a practicing derm PA from Fayetteville, Georgia, and a past president of the SDPA.
Hi, my name's Erin Darguzas. I am a nurse practitioner that specializes in inflammatory bowel disease in Chicago, Illinois.
Hi, I'm Jennifer Hernandez Parra. I'm a nurse practitioner from Miami, Florida, University of Miami, and I specialize in metabolic surgery and obesity medicine.
Thank you. I think this is such a special group, and together we're going to explore the shared challenges and opportunities for APPs navigating this complex clinical landscape. So, Laura, I'm going to just start with you. Let's set the stage. Can we start with an overview of what the data tells us about the relationship between obesity and the risk of developing IMIDs like psoriatic arthritis, psoriasis, and IBD?
Certainly. Well, we know there's a bidirectional relationship. Psoriasis causing obesity and obesity causing psoriasis. And there was a meta-analysis of 6 studies with 2.1 million patients and 200,000 of them having psoriasis. And they found an increased risk of 66% of obesity. With mild psoriasis, it was 46%, but with severe, it was 3 times that at 123%. There was also another 7-study meta-analysis with 700,000 patients and 17,000 of those having psoriasis. And they found even minor increments in BMI, waist circumference, waist to hip ratio, and just small weight changes led to anywhere from 20 to almost 37% increased risk of psoriasis. Also, additionally, there was an obesity risk related to psoriatic arthritis. And that was a bidirectional. Once you got the psoriatic arthritis, you were more prone to getting obesity. And that went all the way up for those BMIs of over 35 to 6.5 times the risk.
Wow, that certainly is impactful and definitely such a reason why we need to have this discussion, and all APPs across all specialties need to understand this. Erin, how have you specifically seen obesity influence disease presentation and progression in the IMID patients?
So we know that in obesity, we'll see an increase in systemic and intestinal inflammation. When we look at the adipose tissue pathophysiologically, we know that when these adipocytes start to enlarge and hypertrophy, that we will see this migration of these pro-inflammatory cytokines, such as various macrophages, interleukin-6, TNF-alpha, and these are the same type of inflammatory cells we see in inflammatory bowel disease. So there is an overlap there.
Absolutely. What about, Laura, talking about skin disease?
To add on to what you said, the adipose tissue is somewhat acting like an endocrine organ, and it is releasing these pro-inflammatory cytokines, which is leading to worse disease and psoriasis. And so you see that increased risk in obesity of worsening psoriatic arthritis, worsening psoriasis. You have some other issues too, as the obesity is worse. You might see friction or skin fold problems, treatment costs go up because the treatments don't work as well.
Absolutely. In my world, which is the joint world, the rheumatology world, obviously weight plays a role in terms of, their inflammatory markers, as well as just their arthritis in general. We used to tell patients every 5 pounds of weight loss, you take 20 pounds of pressure. And while that's true, it's also contributing to this ongoing inflammatory process that's happening. And to your point, they don't respond as well to the therapies. So you're often switching therapies. You're changing frequently. They're not responding. They still have high disease activity. Thus really kind of proving that we need to really tackle this very, very significant problem. And it's more than just the physical outcomes, right? There's so much of an emotional piece to this. And Jennifer, I know you do this day in and day out. So what can you talk to us about in terms of kind of the emotional and social consequences of living with both obesity and an IMID from your experience?
I mean, it's definitely very difficult for patients because, we see a lot of high numbers of depression and anxiety and things like that because, they're not feeling well, they're in pain, they can't really move, they can't, for our older, grandparents, they can't get on the floor with their grandkids to play, or even the young moms who are coming into these things. We're seeing a lot of that. We're also seeing that, with the depression comes then things like the emotional eating. And then that just kind of taps onto an already existing problem. And it just makes it even more difficult.
So it's really just this multifactorial issue that we're dealing, and we can't not think of all of them, right? Like you think about from a skin perspective, from a gut perspective, from a joint perspective, but we cannot forget about the psychological impact.
That plays such a big effect on it, and you've got to be psychologically almost ready also to combat these problems, because if not, then it's, you're doing everything for no reason, because if the patient wants to have that desire and that want to put in the work and do it.
Absolutely. And also even thinking about it from a systems problem. Laura, how do you think the presence of obesity really can alter that healthcare utilization pattern in IMID patients?
That's a good question. I think when patients are obese, their medicines, they might need higher doses of certain medications. They also, it wanes on efficacy. So you end up switching medications more frequently. You end up adding medications. So the cost goes up. And I think that all buys into the overall healthcare dollar that's spent, right? It's a huge, huge amount that's spent in the US each year. And not only that, to the patient. The costs that are associated with switching therapies because this therapy no longer works. So in obesity, we know that not only is it causing disease, but that it's making the medications not work as well.
Erin, what do you see?
Well, in inflammatory bowel disease, we could see a potential increase in surgical risks. As patients are obese with Crohn's disease, we notice that there's a buildup of these inflammatory cells, which ultimately can lead to fibrotic disease, fibrotic stenosis within the small bowel, the large bowel, and ultimately require surgery for repair of that area. So we may see accumulation of costs related to surgeries in our IBD patients. Additionally, we could see increase in hospitalizations for those who have recently undergone surgery or have had prolonged hospitalization time due to risk of an anastomotic leak after surgery or infection after surgery. So it can be impactful when patients are obese and undergoing any planned surgery.
So it's not only the medications and cycling through and using more combinations, which cost more. It's also the hospitalizations. It's the surgeries at these patients. And then let's not also forget about the cardiovascular implications, right? I mean, patients have heart attacks. They are going to potentially need stents. I mean, all of these things that are potentially preventable if we treat these patients appropriately. So, it's interesting because really traditionally, it's really been underemphasized in IMID care pathways. So, Jennifer, can you talk about what needs to change here?
We need to get over the fact that this is kind of an icky topic to speak about. I mean, I'm lucky in the sense by the time they come to me, they've already had a conversation with somebody, whether it's a provider or even within their own family, because maybe they had a relative who had successful weight loss or something due to a certain modality. But, it just be the willingness to have that conversation with the patient when you see, maybe not on the initial consult, but, when you see somebody in the room space, be like, hey, so is it okay? Can we talk about it? Because it really isn't an icky type. It shouldn't be an icky type. Before it was like the stigma of obesity. Oh, they're just lazy and they eat too much. And that's not necessarily the case. There are other reasons why these patients are going through this.
Laura, what are your thoughts?
Well, I think as PAs and NPs, we're very good listeners. We're sometimes the front line of seeing these patients and can show empathy. We know when to refer. They trust us. We're good at seeing them and explaining things. So I think we're uniquely positioned to help them.
Absolutely. And, I would say, the why. Why is this underemphasized? Why have we not talking? I think part of it is we didn't really understand. Like, I have to tell you, 5 years ago, I was not talking about obesity and it causing increased inflammation, right? Like, I didn't know really that it was. Of course, it makes sense. Their CRPs are elevated when they're obese, but I wasn't really thinking about it. So I think part of it is just this lack of education, which hopefully, doing things like this will really help with that to get the word out. And I agree with you, Laura. I think we are uniquely positioned to recognize and talk to our patients about that. I know in my world, again, it's a little bit easier, I think, for me to have a conversation because when they are overweight, it obviously impacts their joints. It causes more joint pain, their knees hurt, their hips hurt, their back, those kinds of things. So I'm able to kind of have that discussion more freely with the patients. Jennifer, what do you think in terms of how can we as APPs really, help our patients understand the importance of this?
Yeah, I think it's obviously because we provide stellar education to our patients, but when you're seeing them in clinic, just, make them understand the correlation between the disease process and the obesity. That it's an important thing to do because a lot of people might not realize that, okay, with the obesity, you have that increased risk of cardiovascular disease or, developing IBD or the psoriatic arthritis, or psoriasis in general. So they need to understand that correlation. This is happening because of that two-way factor. And just, you don't have to be scared to bring it up and discuss it because people are very sensitive in today's world, unfortunately, but you have to be able to kind of set that thing and then just kind of gradually, I think, bring it up to them. And then they'll be more receptive to listening to it.
I completely agree. It's just having an open mind and talking to our patients and kind of meeting them where they are. So, Erin, what about you? Because obviously you're managing patients with IBD. How does that conversation look?
So I think in general for patients with inflammatory bowel disease, nutrition is a very hot topic of conversation. And there's this conception that patients with IBD are cachectic, they are skinny, they have significant weight loss. But the fact of the matter is that 15 to 40% of patients with IBD are actually obese. So it needs to be discussed more often. It's not something that's discussed often in our GI clinic. And so when we incorporate that into a conversation, we can't be scared to have that conversation. It's coming from a place of caring and wanting to get better and giving them the facts of this is also an inflammatory process. We are treating something it's going from one level up here and we're bringing it down to homeostasis. So when you come from it from that perspective, there's a little more understanding of we want to manage not just your IBD, but the whole body. And by doing that, they're ultimately going to have a better quality of life.
So obviously we know multidisciplinary care is essential for managing these complex patients. What can we do to ensure obesity is consistently recognized and addressed as a central driver of disease burden across our specialties? I know for me personally, when I'm talking to patients, I have to be honest. Sometimes we talk about it, and then the next visit, maybe we don't talk about it. And I think I need to be better about actually bringing it up every single visit, or else I think it can be lost. Laura, what do you think?
Well, as I was listening to all of you, I think we need to be educated ourselves and have it down really well on what the process is with the inflammatory cascade. And I think once we educate our peers, they can educate their patients. And I loved what you said about caring for the whole patient. I think in dermatology, we're a little bit uniquely positioned that we may not hit everything every visit. So we kind of parse that out. We might have a complex disease that we hit certain parts of it at each visit. But I think the biggest thing for starters is having events where we bring people together and we do a multidisciplinary approach, and that we learn from one another and we share it with our patients. And that's how we're going to get the whole patient better.
Don't be afraid to make referrals either, you know, because I think a lot of providers get a little bit overwhelmed, and then, you know, they don't realize, I mean, we share space now with a cardiology, with the division of cardiology, and they, one of the new attendings came out and he was like, oh, look, Wegovy. And I'm like, well, no, if you have any patients, I'll be more than happy to, you know, take over the management. He's like, you do that? Really? Like, just shock and awe. Like, I didn't realize I could refer a patient to you to discuss weight loss. Like, it's just that, you know, even within our own colleagues, but just put that referral. If you don't feel comfortable, just be like, hey, listen, I'm worried about you. I'm worried about your weight. I'm going to put a consult into this specialist who specializes in, you know, obesity medicine or, you know, metabolic disease or whatever, and then let them take over. I don't mind taking over from one of my fellow colleagues, because I'll do the same to them when it's something I don't understand very well.
I think one benefit for all of us is that we are in an area where we have this long-term relationship with patients. And so we have built this trust with our patients so that if we want to have these conversations with them in managing not just what you're there for, whether it's IBD, psoriasis, arthritis, that we can have an open dialogue and feel like it's a safe space to do so, because we've developed that over years of seeing each other.
I think that's what's so beautiful about working in these specialties is we get to really see patients for the long haul, right? Like,
and we care.
And we care about them. And I think APPs are just so good at this.
Right.
And, you know, again, I truly believe we are the ones that are going to make a difference in this particular, you know, disease process. So that brings us to the end of today's episode, Obesity and IMIDs, Unpacking the Epidemic and its far-reaching impacts. A huge thank you to our panel of experts for sharing their insights and perspectives across the specialties. This is just the beginning of our IMID obesity series, so please be sure to stay tuned. Future episodes will continue to unpack key themes from our national boot camps, offering practical strategies and multidisciplinary guidance for APPs working in rheumatology, GI, derm, and metabolic health. Be sure to please follow RhAPPcast, GHAPPcast, and Dermcast, whichever platform you prefer, or all of them, so you don't miss what's next. All episodes are also available on the RhAPP ACE 2.0 and GHAPP ACE 2.0 mobile apps, which is an easy, on-the-go access for you. Thanks again for tuning in. We will see you on the next episode focusing on pathophysiologic mechanisms and obesity's role in suboptimal outcomes in IMIDs.